Is our healthcare system broken?
I don't think we have a system.
They're not designed in ways that help them work together.
Why are wait times so long? Why can't I find a family doctor or nurse practitioner?
We have a supply and demand problem in healthcare. We are never going to be able to meet that demand.
This childhood trauma piece is really significant.
I think it's really easy for us as individuals and then for society to kind of put people in this box.
The only thing we see is that they're using substances. Well, they're also someone's child. They're also a really good friend.
If I could wave a magic wand, I would give everybody community.
How, as communities, can we be the healthiest and have the most well-being possible?
And I might imagine something that isn't necessarily technically possible today.
Yeah.
But I do have the agency to picture what I want that to be.
When things are really, really big, I think we have to go really small to like the basic level of what we can control and support.
Every one of us has the agency to be able to do things in our current day, even small things, to start shaping the world. All right, Melissa.
Yes, Yelena.
Let's start with a big question.
Okay.
Is our healthcare system broken?
We're just going to jump right in.
Yeah.
I don't think we have a system. I think we have a number of services. I think we have lots of different sectors and service providers, and I don't think we have a system. I think in order to have a truly integrated system, we need aligned incentives, like payment incentives. We need aligned accountability. Right now, we have hospitals that have accountability agreements for their hospital outcomes. We have primary care organizations that have accountability for their primary care outcomes, mental health organizations. And that's the way that the system is currently held accountable and designed. And so it's by design. Each kind of sector, each organization is really incentivized to think about the results that their organization provides, and their accountability agreements are aligned with that. So I don't think in this current state we can have a truly integrated system of care. We have a lot of services that are working in the system and working really hard to try and provide the best possible care that they can.
Yeah. I had a professor in my MBA program, and it was one of the first things I believe he said when we started the entire program, which was focused on healthcare. And this line has always stuck with me, and I'm sure he'll be quite glad to hear me say it. And he wasn't the one who said it, but I can't remember who the original actual kind of author of this quote was, which is, every system is perfectly designed to get the results it gets. And so when we look at some of the results that we're not happy with necessarily in our current system, or let's say system of systems, we get those results because of the way, those incentives have been laid out, because of the ways accountability has been laid out or not, because of the way things are structured and staffed and integrated or not integrated. And that, I think what really I'm struck with is that there is no unifying, one single leader or leadership team that has oversight over all of these pieces. Right? To your point, we have a hospital system, we have a primary care system, we have social services systems, which all integrate and create health in different spaces. And they're not designed necessarily in ways that help them work together towards the same goals.
Yeah, I agree. My experience has been there is a lot of collaboration across sectors, but it's kind of in spite of all of the, barriers and structural limitations that are in place. And it's all based on relationships, which, some beautiful things can happen from that. But I think we could benefit from having some of those structural changes. One of the systems I'm very interested in is South Central Foundation in Alaska. So they have funding for the entire system instead of having hospitals funded, to deliver these outcomes. And they have funding to run the entire health system there. And what they did decades ago was take money out of their emergency departments and really heavily invest in their primary care. And they built all of the mental health and addiction supports into primary care. And they really looked at improving access, improving cultural and traditional supports for the clients that were there. And they saw a significant reduction in kind of emergency services more generally. But it took a huge shift, and it took, one organization being able to see that whole system and move resources around creatively to kind of make some of these changes happen. But they've seen some just significant improvements, and they're one of the health systems that a lot of, people around the world are looking to for leadership and ideas about how we can do things a bit differently.
I love that it's a place-based and population-based approach,
Mm-hmm.
right? Looking at, rather than starting from a service orientation where we're going to say, what does our hospital need? What does our
Yeah,
primary care need? Um, what do our acute care centers need? It's saying, what does our population need?
exactly.
And then building the services around that.
Yeah.
Yeah.
Yeah, I think that's a really important piece and principle that we really need to have in our context here. And it is happening in pockets, right? We have lots of partnerships that are happening in our local system. I see it all the time. Really taking a population based approach, which is really just asking the question, what does our community need? What are some of the health needs that they have? What are some of the social service needs that they have? And how can we work together to deliver that in the most low barrier accessible way possible? So I do see it happening a lot. It's just not in a structural kind of systematic way. Mm-hmm.
I think Guelph is in some ways a leader in this space.
Mm-hmm.
I know, the community health center where you work, the hospital, local family health team,
Mm-hmm.
other kind of agencies within the region actually work quite closely together and partner on many initiatives.
Yeah,
Are you interested in telling us about any of those?
sure. I think we really benefit in this community. We're small enough that many of us have been working in this system for a long time. So we've had a long time to build trust, build relationships. And when you have that, you can do a lot together.
Mm-hmm.
We also are lucky enough to kind of have a system where we have, one large family health team. We have one CHC. We have one acute care hospital. We have one, large mental health and addiction service provider. In a lot of other communities, they have many, many, many within each of that space, which makes it harder to figure out, who are my partners and how do we organize ourselves when there's just so many providers. So those are some of the things I'm really grateful for working in this system, and some of the examples of really cool collaborations that are really looking across sectors, across disciplines. One example is our permanent supportive housing project. So this was a multi-partner project where just last year we opened a 32-unit permanent supportive housing building, which is really those two things. It's permanent housing with 24/7 supports to support people that were experiencing chronic homelessness, and really bringing in the supports and services that they need to maintain their housing. And the only way that really happened was we had a nonprofit landlord, Kindle Communities, who had a land donation and really wanted to do something meaningful with it. So they had kind of the land, and they have the expertise on building a building, which we certainly don't. But they wanted to bring in a health partner right from the beginning and say, look, we have to start thinking about the health needs of the people that are going to live here right at the outset. We knew right away we're not a housing provider. We don't provide 24/7 services. So we said, we'll be the health partner, but we also need a partner that has the expertise in addiction supportive housing, for example, and mental health supports and all the other things. So we started chatting with Stonehenge Therapeutic Community, another really important partner of ours. And we designed a partnership agreement right from the beginning with the three of us, where we really brought each of our unique contributions, gifts, and skills to the table. And I really do think that's how we were successful. We raised about $10 million in capital funding for the building, which is amazing. That building is mortgage free. And we also collaborated, we did shared advocacy, and we were able to secure operating funding for the building that was needed. And I truly don't think we could have got to where we got to without that level of collaboration. And I didn't even mention yet, like the private sector partnerships there, with Skyline and Skydev, like land donation and all levels of government contributing to capital. And I think that would have never happened if we didn't have this kind of multi-partner arrangement. And I will say it's harder to do that.
Yeah.
It's easier and less complicated when you just do everything yourself. But I don't think you can get as much done. And when you have these multi-partner kind of arrangements, you really need to dig in deep, and you really need to understand, how are we going to work together when conflict comes up, when challenges come up? How are we going to work through that together in a way that creates alignment? So it takes a little longer, and it's definitely more complex, but I think you get way better outcomes at the end of the day. So Yelena, now I have a big question for you.
Okay.
We hear a lot, like I hear this from family and friends, and I hear this from clients as well, in our organization, like questions about concerns around the health system. Like, why are wait times so long? Why can't I find a family doctor or nurse practitioner? You know, there's so many challenges in our system, and I'm curious what you're seeing as some of the root causes of our kind of general capacity issues in the healthcare system.
Yeah. So this drug goes back to, really taking a systems perspective. At its core, we have a supply and demand problem in healthcare.
Mm-hmm.
So over the last number of decades, as I'm sure you know, we have people who are living longer with illnesses that, previously might have actually killed them earlier in time.
Mm-hmm.
So, heart attacks, for example, we can do more for people now than we could have done, many decades ago. And, because of our lifestyle and our diet and, the way that our society is structured, with, let's say, more driving and less healthy food, we really have this increase in burden of disease that is not acute and not able to be dealt with simply a short hospital stay or one medication or a surgery. We have people who are needing more out of our healthcare system over longer periods of time.
Mm-hmm.
So that's our supply side. At the same time, we have, as everybody does, a limited number of humans and a limited amount of money to put into our healthcare system. So as our demand continues to increase, our supply really maintains relatively stagnant.
Mm-hmm.
And on top of that, our population kind of demographic changes, which means that, we have an older population. Many people are retiring. And so that impacts both the demand side with older people requiring more healthcare, and it impacts the supply side with, many people retiring from professions such as nursing or medicine.
Mm-hmm.
And so, at its surface, it would seem like, okay, well, we need more doctors, we need more nurses, we need more hospital beds. But really, we are never, in the system as it currently stands, we are never going to be able to meet that demand, with the number of people that we have and the amount of money that we have to deliver to that. And that's pure kind of demographics and economics. It's not a matter of a government just needing to continue to give more money, because at some point that money will run out, even if they do that. So we need to come up with different solutions to that problem that either deliver care in a different way, that perhaps uses people differently or uses different kinds of people to do certain jobs, or uses technology to support our people to be able to do, only the kinds of work that humans really need to do.
Mm-hmm.
Or we need to work on the supply side and see what can we do to actually reduce people's dependence on the healthcare system.
Mm-hmm.
And I'm sure you have some thoughts about that.
I think that's really important. I think we're not always asking the right questions. So when people are asking, like, why is the wait time at the hospital so long, or why can't I find, a family doctor or nurse practitioner, I think we need to kind of back up the truck a little bit and really look at what are the root causes of poor health And how do we get to true kind of health and well-being at a community level? The answer certainly does not lie in the emergency department, and it doesn't even lie in the family doctor or nurse practitioner's office. We know there's lots of good data and research and information that is decades old that tells us that the actual healthcare system, so the formal system, only contributes to someone's overall health and well-being 20%. So what makes up someone's overall health and well-being? What's that other 80% made of? And this is something called the social determinants of health, which there's been decades of information and reports and recommendations on, right? These are things like the basic things that people need to be healthy and well is stable housing, stable income, access to healthy food, access to a support system, community connection and belonging, education, support, freedom from structural oppression. Like there's all of these things that are contributing to someone's overall health and well-being. So we can look at the heart attack, we can look at, the diabetes, but at the same time, we need to be looking at, do you have transportation to get to where you need to be going? If you have diabetes, we're going to prescribe insulin and do all those things, but we're also going to ask you, do you have access to healthy food? Do you have somewhere to go and people to connect with during the day that you care about and who care about you? These are all of the things that we need to really be looking at. And so I think we need to really back up the focus and stop focusing on, the emergency departments and the other things, and really look at the question should be, how as communities can we be the healthiest and have the most well-being possible? And that is, we're going to have a whole different discussion about community resilience, community connection, overall well-being, and not just the absence of illness, which I think is kind of how our health system is built. So I really am passionate about this. I have a background in public health, and I really think this is the way forward. And I'm curious from your perspective as a physician, what are you seeing and what's your perspective on kind of this idea of like early prevention, health promotion, early intervention?
So I really love that you brought up social determinants of health. We've had this conversation before, you and I.
Yes, we have.
You know that, this is a place where I am increasingly focusing. So after 12 years as a physician, working primarily in substance use and mental health, a little bit also in primary care, I keep coming back to this space, right? I keep seeing in my practice that, there's only so far I can take someone in terms of their health and well-being with, a diagnosis and a medication, and even in the type of kind of supportive counseling and therapy that I can give, which gives some of that social support, but it's different than what you talked about somebody having, their own community that isn't a professional.
Yeah, exactly. This is really interesting. Like in your practice, when you think about being presented with that, right? You've got someone in your office and you're supporting them. What would be like your kind of wish list of like, what would you love to have as a support and resource in your practice to kind of give that patient what you think they need most in that moment?
That's a really great question. If I could wave a magic wand, I would give everybody community. Right?
Yeah.
I don't know how you do that.
Yeah.
That's, perhaps a question for us to think about a bit more deeply.
Yeah.
But I think there's so much value in people finding a space where they feel like they belong, where they feel seen and heard and cared for. And it doesn't always have to be super deep in the sense of, it doesn't necessarily have to be that this person in your community circle knows every single thing about you, and you trust them with your life. Like we know there's some really great research on the value. It's called the value of weak ties. That even people who go to a coffee shop every day. So this is really some really fun research.
Yeah.
If you go to a coffee shop every day, there's some research that shows if you take a minute and you chat with your barista, versus the people who just go and order their coffee, the people who are sitting and having that chat, even if it's for a couple of minutes and they don't know that person super well, they get more of a sense of wellness out of that. Like that contributes to their overall sense of having a community and feeling their belonging. And so community doesn't have to be
feeling seen and like someone knows you and cares about you.
Yeah.
And, I believe in the power of therapy and counseling and like these clinical interventions. Absolutely. But there are also like therapeutic benefits to these types of relationships, right? Whether it's with family, friends, deep connections, and also just people that, you see and that know you in your community, that you feel like care about you. And if you didn't show up that day to the coffee shop, they would care about you and they would wonder like, where are you? And check in. Are you okay? Like these are the things that make community. And I think this piece is so important. I know it sounds really funny to hear a physician say, if I could give my patient anything in this exam room, it would be community. But I think this is important to kind of dig into a bit more, because belonging and connection is so important to our overall well-being. And we're actually wired as human beings for connection.
Mm-hmm.
It's how we survived. And these things are still there. So how do we, the answers lie outside the health system. They lie outside the exam room. What are some things that you're seeing or hearing like that are kind of important for us to pay attention to in terms of creating, community well-being and belonging and connection?
So I'm gonna back up slightly, and I want to amend my answer just a tiny bit, because yes, community, but also some really practical things: housing, food, income. Right. These are the other things that many of my patients, like yes, they come to me to get help with their substance use, but the thing that is most important to them is that they have a safe place to live. That they have income to be able to buy food. And so community, yes, and the practical things.
And the basic, it's kind of like, I think you're talking a bit about Maslow's hierarchy, right? Like these things we need, basic things that we need. And as you get further up that hierarchy, we start to get to these things about connection, belonging, like how do we have fulfillment?
Yeah, what I find interesting is even, when you think about some of the people I know that I see in my practice, and which I know are also some similar people who you might see at the community health center. What I find interesting about thinking about Maslow is I don't know that I love the hierarchy as a hierarchy, because I think that even people who don't, let's say, have housing can still have community, and there can still be a real meaning and support and some degree of wellness from having other people around who see you as you are, see you, beyond your label as someone who has a substance use disorder or a mental illness, or is unhoused. And there's real community that we see amongst those populations, and sometimes I think that goes unnoticed or unappreciated.
This idea of community connection and kind of these links between the health system and this broader sense of well-being, I think is really important. I wanted to talk a little bit about this notion of social prescribing. And I'd love to hear your, like, from a physician perspective and any kind of examples that you're hearing. But we've been doing social prescribing at the community health center for about 6 years. And really what that is at a basic level, just as your family doctor or nurse practitioner might prescribe a medication for you or might make a referral to a specialist for you, they're also looking at you more holistically as a client and looking at, do you have access to healthy food? Do you have access to social connection and belonging or activity? And they actually make a prescription for that type of thing. And then we have community connectors that meet with clients and ask them, like, hey, where do you live? What kinds of things do you like to do? How can we get you connected with things that we know are in community that are kind of meeting that social prescription? And I think this is a way that the health system is kind of identifying that we need broader supports to support health and well-being and trying to make those connections. So I'm curious about what you think about that.
I mean, I love that you brought that up. It's something I have been thinking a lot about lately. For this exact reason, health is created outside of the healthcare system largely.
Yes.
And yet, because of the way that our society thinks about health, people show up to the healthcare system to get help.
Yeah.
Right. And so many of the visits that come into a primary care provider, a family doctor, a nurse practitioner, even the emergency room, yes, people might be walking in talking about their blood sugar, for example, to go back to the diabetes example. But the underlying issue to that, it might not be something that the physician is in a position or the healthcare system is in a position to help.
And so often it's not.
Yes.
And what I hear, and I'm curious what you hear with your colleagues, is that systemic barrier where, physicians and nurse practitioners and got into this work to support people. And the supports that people need are not what they can offer. And that's leading to a lot of burnout as well. So what do you see?
Absolutely. I think, nobody goes into healthcare, or people go into healthcare because they want to make a difference. They want to support, they want to help the people in front of them. And, we are trained as physicians or nurses to, do an assessment, make a diagnosis, create a treatment plan, and then give advice. And that advice might include medication.
You're paid to have the answers.
Yeah, that's a really good point, Melissa. We are paid to have the answers, and a lot of the times we don't have the answers. And I think, being a good clinician requires getting into a space where you are okay with the fact that you don't have all the answers, right? And yet, obviously, we want to be able to help people. And so when the help that people need is actually systemic and structural and not a medication or a surgery, then it becomes really hard for us to know, what to do. And there's a limit to what advice giving can do, right? And this is a lot of, as you know,
especially in a 10-minute appointment or whatever time that you have available.
People don't change because you tell them to change. No. People don't change because you point out how their current behaviors are bad or healthy, right? Smoking is a great example of this. People who smoke know that it's unhealthy to smoke. They're not continuing to smoke simply because they don't care about their health. Right. There are all sorts of other motivations, sometimes physiological things like dependence, but also, social factors, stress-related factors. There's a lot of reasons why people, behave in ways that ultimately contribute to their poor health, and much of that is actually, within our systems and structures. And so a physician or a nurse is limited, and we're limited in how we can support with that.
Can we talk about this is, I think, a really important theme is you mentioned that nurses and doctors are trained to kind of pretty quickly, assess a situation, find a solution, provide the answers. And the solutions that are truly needed are not available to the patient and physician in that exam room. And so I'm curious about maintaining our humanity, because that process is pretty clinical, right? It's here's your problem, here's the solution, your problem's your low blood sugar. We're gonna, and how do we see people as whole people? And how do we maintain as, people working in the system, our full humanity as well?
So I think the most primary way, so I can speak from my own experience, is in focusing on the relationship. And so even if I have a patient in front of me who has a challenge that I can't directly fix, right? I can't say, here's the medication that's magically going to make you better. But it's something that perhaps with some combination of some behavior change on their part or some access to different types of supports and services that we can at least make a dent in. The key to me is on keeping the focus on the relationship between myself and that patient, and really getting to know what's important to them. What do they care about? What motivates them? Is this problem even a problem that they see as being a priority in their life at the moment? Because I might look at it and think, wow, this should be a big priority. This is, impacting your health. But they might have some other priorities that are more important to them at that time. And my best way of helping them in their life with what they need is by focusing on them and that issue. And maybe reminding them every now and then about this other priority that I think is important, but at the end of the day, taking lead from what they want in their life, and keeping that relationship strong and trusting, so that I can help them move in the direction they want to move. And then perhaps at some point later, they might be ready or willing or interested in talking about, this other thing that I might think is important, but isn't a priority to them at the moment. So I'm going to bring that back to social prescribing, because it's not a thing that I have had the opportunity to actually do. I'm aware that it happens in certain places, like at the community health center. I'm aware that it is quite well established in the UK. With, a structure and a whole system.
A more systemic structure.
Around, having workers in place, having funding in place to be able to connect people to, supports and services and community-based organizations.
Okay, given that you've talked about how important the relationship is between, the doctor, nurse, and the patient, in a system that we have way more demand than we have capacity to manage, how do you as a physician make time to build a relationship with your client or with your patient in this, when you've got 10 other people waiting in line for you? How do you do that?
It's a really good question, and it is one that I think all clinicians are struggling with these days.
I see that too.
I can't speak for everybody, but I can speak for some of the things that I do, both very specifically in the patient interaction, and then things I do in my own kind of how I structure my practice, and how I bring myself to the work to try to help that. So in the actual interaction with someone, I would argue it actually doesn't take that much time to build relationship. I think even in, if I have 5 minutes, for those 5 minutes, I am focused entirely on that person in front of me. I might have 10 other things that are going on in the background, but that person gets all of my attention. For as short as it is, they get my attention for that amount of time. And people can feel that. There's a lot you can do in 5 minutes, if you are willing to ask some questions and listen. And there's some great research. I'm not going to get it correct, but showing that on average, doctors interrupt their patients some very large number of times in a short appointment. I can't remember the numbers, but by being conscious of just letting someone talk, maybe for the first 2 minutes without interrupting them, and asking some follow-up questions that demonstrate that you've been listening. So, reflecting back to something that somebody has said, summarizing what they've said, asking, do I have this correct? When you're making an interpretation, that act of intentional listening and letting someone get out what they want to say, and then demonstrating through, your words back to them that you have heard, that starts to build trust.
And I imagine, like, without trust in that relationship, you together as a partnership can't get anything done. Right?
No.
So taking that time up front, it might be, even if it was a little bit more time up front, I imagine it would allow things to move more smoothly further down the road. And as you're trying to, address some of these other things, they need to believe that you care about what's important to them.
Absolutely.
And that you're listening to them as well.
Absolutely.
And I'm really curious, a lot of people, I think, expect their doctor or nurse to have all the answers when they come in, to be able to do everything, right? How do you're also a person and you've got, other things going on in your life that day when you're coming into the clinic for the day. daycare canceled and you had to like, I don't know, like there's a million things that happen before you show up. And so I'm curious how you kind of show up in a human way too with your clients and let them know that you're a person as well. And you also need to be taken care of, just like they do.
Yeah, I think for me, it's about being authentically myself. It's not necessarily about a lot of self-disclosure.
Yeah, I
I
agree.
think there can be a space for self-disclosure, and
Yeah.
for those who don't know what I mean by that, that means necessarily, telling them about what's going on in my life.
Yeah.
I Some people do that more than others,
Yeah.
and I think it can have a place. I think, when I'm in that moment with my patient, that moment is about them and not me. But I also don't try to pretend. I don't necessarily have a professional persona that is different. I come to work dressed like I normally would dress largely.
Yeah.
Um, I, I smile, I'm warm. Um, and I think one of the way I might bring in my humanness is to be really transparent with people about what I can and cannot do. So not
Yeah.
pretending I have the answers when I don't have the answers.
Yeah.
Being able to say, actually, I'm not really sure what's going on here.
Yeah.
So we're going to work it out together, and
Yeah.
I might be able to tell you, it's not this thing or this thing that I'm not worried about any of these big problematic things. But in fact, I can't, I don't know the answer. And, maybe we're going to give it some time,
Mm-hmm.
and we're going to come back together again to see how things develop. Or, maybe I'm going to go off and I'm going to ask somebody else a question.
Yeah.
And I think being able to acknowledge when you don't know something and being
That
able to
also builds trust.
100%.
Like, really,
Yeah.
we don't have all the answers all the time, and it's okay to say that.
Yeah.
And I do think that is part of being human in the space. And that can happen in an individual interaction with a patient, but it's also at a system level, right? Like we get questions from clients and I get questions from staff all the time about things that absolutely do not make sense, right? Like about how funding works in the system or whatever. And I think part of that is also being human from a leadership perspective, of saying, you're right, that's an inequity in our system. And I totally agree with you. And I don't have a solution for that. Like some of
Yeah.
these things are big systemic inequities in our systems that need to be addressed. And that's going to happen over a really long time. I'm really curious. I'd like to dig in. So you talked about, you gave an example of like someone coming in, maybe with a substance use health need. And maybe they also are looking for housing and other things. I'd like to take like one example like that and kind of work it back as we're talking about looking at the root causes of things. I think substance use is a really good example where the substance use isn't necessarily the problem or the issue. It's oftentimes, people are using substances as a way of coping with other things going on. And I want to just use this as one example. We could look at any kinds of things, heart disease, like um, all kinds of other pieces. Like what kind of something came before that, right?
Mm.
And so I wanted to dig a little bit deeper into this idea of like early prevention, early help, and really talking about like early childhood
Yeah.
and the supports that are needed to build community around families, around children in those early years. Children that experience chronic stress, chronic adversity in early life, their brains actually get
Mm.
rewired to be more susceptible to mental health needs and issues, substance use issues,
And physical health
and
issues.
physical health
Yeah.
issues. And it sets them up on a trajectory that is going to be, really guiding the rest of their life. So I'm wondering about if you can talk a little bit about that connection to some of the issues we're seeing in our communities now related to substance use health, related to mental health, and how we kind of back up the bus and start really talking about investing in and supporting, young families,
Yeah.
kids, and really wrapping community around them.
Yeah. I'm working in a couple of different settings. One of them is a detox setting where, you know,
Mm.
I would say not everybody So I always hesitate to kind of use a blanket
Yeah.
statement, but the vast majority of the people that I see have some type of early childhood trauma.
Hmm.
Um, Many of them have several, and I think there's a cycle that happens. There's a cycle that happens, I think, for people individually, and then we know there's an intergenerational cycle
Yeah.
that can happen around trauma, where people may not have the supports that they need in childhood, that then um, makes them at higher risk of having something like a substance use disorder, which also impacts their employability and their access to housing,
Yeah.
which can ultimately leave people in circumstances where they are more likely to be exposed to more trauma.
So, having adverse experiences in childhood or being exposed to chronic stress in childhood doesn't necessarily mean you are set on a
Yeah.
course that cannot be changed. I think one of the most important things to know in communities is we can do something about that as individuals, as families, as communities, and they're called protective factors. So these are things like caring teachers in a child's life, family members that come over and support with walking to school and helping out around the house to make sure that the parents aren't as stressed, and then they can show up in the ways that they want to for their child. It can be a soccer coach who had like a really significant impact. So some of the work that we do at the community health center, and there actually is a group in Guelph called the Community Resilience Coalition.
Mm.
And this is what they are looking at is how do we intervene? This is the hopeful part of the
Yes.
story, right? Is just because someone experiences trauma, that's not their whole story, and that it's not like their fate is sealed, right? There are ways that communities can really show up for one another to bring these protective factors around a child and around a family unit, to make sure that they are building that resilience over time. And so the Community Resilience Coalition actually has training online that is available to talk about this process. And they train soccer coaches, and they train, teachers, and they train all of these other folks to really identify the positive role that anyone in a child's life, doesn't have to be their immediate family, can play in supporting resilience of children and families. And I think this is something we can dig into more, because this is a low cost, low barrier solution that really will save the health system capacity issues that we've been talking about later down the road. But this is like decades of investment and intention that we have to build together as a community.
I love this so much, and I love how it brings us full circle back to the
Yeah.
concept of community.
Yeah.
Because I'm always conscious when I'm talking about the people that I treat, the people who come to see me who have
Mhm.
substance use disorders, who have often have trauma, who have other chronic diseases. I'm really conscious of not wanting to make that their whole story,
Yeah.
right? I'm really conscious of, I think it's really easy for us as individuals and then for society to kind of put people in this box and say that's
Yeah.
all that you are or all that you're ever going to be. And that is both untrue and damaging.
It's really polarizing communities
Yeah.
too, when we say, this person is, the only thing we see is that they're using substances. Well, they're also someone's child. They're also a really good friend to, they also have all these other, they play the guitar. They like,
Yeah.
and I think it's really important that we broaden and really see people holistically, and also understand that this childhood trauma piece is really significant. It's not what's wrong with this person. It's like what happened, and
Yeah.
how can we build supports around that?
And that sentence you just said kind of reminded me of, so I've been also thinking a lot about social prescribing lately. And one of the sentences that comes up, kind of a catchphrase in social prescribing, is rather than focusing on what's the matter with you,
Mm-hmm.
saying what matters to you.
Yeah.
Right. So this idea of community resilience and having regular everyday members of the community learn some skills that can help them be a positive influence in anybody's life, right?
Yeah.
And you don't have to know about what has happened in someone's life to do that. So the idea of trauma informed communication or trauma informed care, if you're a clinician, or trauma-informed leadership
Mm-hmm.
is to just assume that all of us at some point have had things in our lives that have been traumatic, and that can be, big or small. It can express differently for different people, and some people's, defining trauma is I think very personal.
Mm-hmm.
But everyone can benefit from an approach of, from a trauma-informed approach of how we relate to each other.
I think this is also like really important about broadening what we think of as the care team for a person, right? A person's team isn't just their family doctor or their nurse or their social worker or whoever's on their clinical team, but their team could also be their community, their family, their friends, other people in their life, the barista. Like, I think this is just bringing it a bit full circle in how we really build community as a strategy for improving health and well-being, and not just focusing on, oh, we need more healthcare services, we need more hospital beds, we need more family doctors and nurse practitioners. We actually need community. We need housing. We need food, fresh food. Like, these are the things that I think we need to be focusing on.
All right, Melissa.
Yeah.
How do you maintain your passion for the work that you do?
It can be really hard at times because we are in a very challenging time on so many levels. I really maintain my passion and inspiration by really focusing on the people around me that I can support, influence, that can also support me, and doing some of these things we talked about that is really simple. It has a really powerful impact, and that's creating community and connection. I see it every day when I look around me with all the people I work with, and they're creating community and connection with all the clients, with one another, to support one another. I get a lot of inspiration and motivation to keep going when I see how people on the front lines are doing it every day with a great deal of compassion and advocacy and support and connection. So those are the things I really focus on, because I think when things are really, really big, I think we have to go really small to like the basic level of what we can control and support, because then we see the impact of that every day. Yeah.
Interesting. I would say if I were to answer the same question, there are similarities. Like that going deep into the personal, like, who is that person in front of me? What are the moments of care, that I can pull out? And I even think back to the last week that I was working in the detox setting that I was at, and some very specific interactions where we had moments. I had moments of feeling really connected to the person I was working with, and moments where I felt I was delivering good care. It wasn't about a solution. It was just about caring. And where I felt that they felt that care. And that helps me. But also, I also like to go big. And I found more and more for me at the stage where I'm at in my career right now, what keeps me going is a combination of imagination and agency. So really being able to think about what could be different in the future. If I were to imagine a different system or a different system of systems, what would that look like?
I love this, because imagination is something that no one can take away from you either.
That's great. So, absolutely. And I might imagine something that isn't necessarily technically possible today. But I do have the agency to picture what I want that to be, and then ask myself, what's one thing I can start working on today that would get me and or the system closer?
And who can I bring along that has that shared vision to help me? That's another thing that keeps me hopeful in this time, is partnerships, allies, people that come alongside and want to get up to the same good trouble that I want to get up to, like you, and start imagining together in teams as well, which I think is
honestly the thing. There's a for anyone who's interested, there's a book called Imaginable, and there's a concept called urgent optimism, which is really about
I love that.
this idea of imagining a variety of possible futures. Thinking about which of those futures do we want or not want, and then recognizing that every one of us has the agency to be able to do things in our current day,
Yeah.
even small things, to start shaping the world into to make it more likely that vision that we have will come true.
Yeah.
And that absolutely keeps me going right now.
Okay, great. Amazing.